Well, thank you very much for that introduction, Megan. My name is Kristin Ormhaug, and I work at the Norwegian Directorate of Health. I'm one of those people who put other when you had the three different options there, because we are a technical executive body under the Ministry of Health and Care. So we are providing analysis and advice up to the ministry. We have some legal work, and we have a lot of emergency responsibility, and we have different roles. And then it's up to the policymakers really sitting in the ministry to decide what they're going to do about the advice that we give. And then we have to carry out what they decide later. I'm here today with Jia Jiang from Statistics Norway. I don't know if you want to just briefly say hi, Jia.
My name is Jia. I'm a researcher at the Research Department at Statistics Norway. So here in Statistics Norway, we do a little bit more on modeling side. We do the projection models, and not only for health services, we also do population projections, and that gives us actually a quite good foundation and opportunities to do health professional modelings. So I'm very excited to be part of this innovation lab. I was here on Monday, and I find that there's a lot of things we can learn from each other, especially the similarities and the challenges that we're facing. I think it's a very good opportunity for us to learn from each other. I think they will help us quite a bit in our progress. There's really so much for us to learn. So I'm looking forward to the other sections and sessions, and I'm looking forward also presentation today, so that he will give you a quick introduction of modeling aspect of the Norwegian national projection model on healthcare professionals. Yeah.
Yes. Okay, and then I will start out by talking a little bit about the Norwegian healthcare system and the context. And then Jia will give you more of the details of the national model afterwards. There. Can you see my presentation?
Yes.
Yeah, okay. I can't see you, so you have to shout out if there is anything. Okay. This is a map of Norway, and that is quite relevant for understanding how we use the projections and how the policy works. The goal that we have is to provide equal healthcare, or perhaps a better translation is healthcare of equal value, to the entire population where they live. And this has been a central goal for Norwegian healthcare policy for many years through shifting governments. And so that's not going to change over the next few years. But as you can see, we have a population which is very decentralized. So compared to, for example, Sweden, we're very similar to Sweden in many other aspects, but they have a much more centralized population, whereas we are scattered all over the country. There's 5.5 million of us, and we live in 15 countries and 357 municipalities. And they vary enormously in size and in population. So the smallest one has just 215. The smallest municipality has just 215 inhabitants. And then you have Oslo with over 700,000. And they have, in theory, the same responsibility, which I will get back to. This is we were just having a chat with Canada. It's a very nice country with the beautiful mountains and fjords, but of course it's a bit challenging to provide equal healthcare all across this landscape. So you might have heard that we have a very high density of healthcare workers. That has a lot to do with this distributed population and how we have rigged our healthcare services. The second part of the slide there, we have, as many other countries, an aging population, and especially in rural areas. So some of the problems in the rural areas are compounded by this fact. We have relatively good health outcomes, life expectancy above 82 years, and we have a low fertility rate. So I think this is something we share with quite a few of the other countries here. This is just a quick picture to give you an overview of the healthcare sector and how it's governed. The main takeaway here is that responsibilities are divided. You have the Ministry of Health and Care Services in the middle, and we are in the box there on the right as a subordinate agency, the Directorate of Health. And then the boxes under the ministry show that you have the regional health authorities on regional level, which govern the hospitals and the specialist care. And then in the middle, you have counties, county level. They provide dental care. And then the municipalities provide the primary care. I shall go a little bit more into this. So the first two levels that I talk about, the specialist healthcare is governed, or I think the correct term is owned actually, by the Ministry of Health and Care. And there are 4 regional health authorities that govern the hospitals and that are essentially responsible for specialist healthcare services. And they have direct communication with the ministry and a sort of line of communication there. And then on the second level, we have the dental healthcare that I mentioned, which is the responsibility of 15 different counties. And dental healthcare is composed of about 3/4 private providers. And this is very unlike the rest of the healthcare system in Norway, which is to a very large degree a public system. When it comes to modeling and projections, the 4 regional health authorities, they have their own analysis sections and they have their own model. The model that Gia and I will talk most about today is the Helsemod, is the national level projection, but the 4 regional health authorities are using their own model, which is a lot more specific and tailored to their needs. It's more detailed and more complex, speaking to this issue of complexity that you've talked about. And then when it comes to the municipality level, this is perhaps a bit more unusual, I've understood after talking to some other countries, that we have, first of all, a very extensive primary health care. The different responsibilities are listed there. And it is entirely the responsibility of the municipalities. So, as I mentioned earlier, the smallest one has 215 inhabitants, and then we have Oslo, over 700,000, and they have, in theory, all the same responsibility. One of the key things is the general practitioner scheme, which is there. This is a very, the population has a right to keep the same, to be part of one particular GP's scheme, to be on their list, as we call it. And some interesting research has shown that there is, with increasing length of this personal relation to your GP, there is actually decreased mortality and decreased use of out of hours emergency care, for example. So this is a very valuable part of our healthcare system. And I also think, I'm not totally sure about this, but I also think that Norwegian GPs are expected to treat maybe a bit more, or to handle a few more situations that might have been sent to specialist healthcare in other countries. And they function as gatekeepers to the specialist healthcare sector. Yeah. And the second bullet point, we have nursing care within and outside of institutions, including long-term care. So we have a very high density of nurses, and it's partially because we have our long-term care is actually staffed with nurses. I've also understood that that's a little bit unusual. And then you have the other parts of the list there. Local democracy is very strong in Norway. We don't really like to be governed by central authorities. And a few years back, there was a commission looking into whether it was right for all the municipalities to have all the same responsibilities, given the large variation. And they actually concluded that we shall continue with this model. But as you can understand, it's not that easy for delivering healthcare services. Right. Now, how do we go from forecasting to policy? There was an independent commission. The commission was commissioned by the Ministry of Health and Care. And they published an analysis of the future of the Norwegian health workforce in 2023 with the apt name Time for Action. And the Helsemod projections, the model that Gia will talk about, clearly show that if we continue delivering healthcare services the way we do now, there will be a severe lack of healthcare personnel by 2040, and not to mention 2060. The numbers are pretty crazy. When this was presented, it generated a lot of public debate, and I was quite, I think I can say I was quite disappointed in at least the first round of public debate, because people were starting to question the numbers, and we're pretty sure about these numbers. There was some almost anger from the healthcare community because it was said very clearly that in the future there will have to be more patients per healthcare personnel. So there was, this stirred up a lot of debate. But since then, I think the facts have kind of set in, and people have realized this. So, we need to do something about how we deliver healthcare and how we're going to take this forward. The ministry have laid out their plan, basically in the white paper, the National Health and Coordination Plan. And they have singled out health workforce as one of the central issues that are addressing, and they have grouped their actions in 3 points. The first is working environment and working conditions. The second is appropriate task sharing and efficient organizing of work processes. And the third is stable access to personnel. So they are placing a focus on recruitment, qualification, and competence development, and ways of retaining and using the health workforce better. And I'll just end here as my last slide. The sort of overarching conclusion which we have reached in Norway is that the government agrees, this is what they said in the white paper, they agree with the Health Workforce Commission's analysis of a tight labour market for all sectors moving forward, and that the health and care services share of total workforce can't continue to increase significantly. So the word significantly is important here. It doesn't mean zero growth, but we can't keep taking more and more, a larger and larger share of the national health workforce in total. And, like many countries, we've been in a situation where there was expansion of the workforce over many years, and we've solved most problems by just chucking in more and more health and care personnel, but we can't continue on that path going forward. So this was a main conclusion that we've reached here. So And very concretely, they are introducing a new requirement that consequences for the health workforce must be assessed for all measures within the ministry's sectoral responsibility. So, for example, in the Directorate of Health, we have a new requirement when we are introducing, for example, new analyses or new what's the word? We are issuing recommendations on how to treat patients, for example. And the requirement now is to include, before we kind of come out with a gold standard, we have to, as we have used to do, we have to include include an analysis on how this will affect the availability of healthcare personnel. We have to be more realistic in that assessment. So I'm just going to say, so we have in Norway this very dispersed population, the very divided responsibilities with the overall, the Helsemod, the national projections. Then you have the hospital sector on the second level, that they have their own projections, which are a lot more specific for different medical specializations, for example. And then you have the dental and the municipality level, where they don't use projections to the same degree, and they present a more varied picture, if you like. So for those of us who are sitting in my chair and with the national responsibility and trying to provide analysis and advice for the policymakers, it's been very useful to have a relatively simple model, not a super complex one, but a simple model that I know pretty well. I know what goes into it, I know what comes out of it, and that gives me that makes me more confident in the advice that I'm going to give the politicians. You know, there's no, it's not like a black box and I am not sure why this number has come up when I'm going to give advice. So that's it's not complex enough for the hospital sector, for example, or for a local planner, but on the national level, this relative simplicity of the model is very helpful. Yeah, I'm going to stop there and give the word over to yeah.
You see my screen?
Yes.
Great. I'm going to talk about, thanks Christian for the introductions of the Norwegian health system. You know, I'm going to talk about the projections and of supply and demand for health professionals. This is a very brief introductions of the Norwegian national level model. And see. Okay. This has been in use, you know, this what we have a name for this national projection model called the Helsemod. It has been in use since like middle of 1990s. So we started really early in our practice, but we have been a quite small team who work on this model. The underlying ideas and the concept are relatively simple and straightforward, as Christian has talked about, and the model structures are also not very complicated. Well, the goal is that we're going to try to use the available register data as best as we can, but still being kind of transparent and trackable. You know, in Norway, what we really have is we have very good register data, both on labor supply, you know, labor input and on patient level. So that gave us a very good opportunity. And we are trying to see, okay, given the idea that we have to have the model to be transparent and trackable, how we can make use of data as best as we can. So what do we have here? You know, I started with the main data sources for projections. And it has to have like population projections. You know, in the state of Norway, you know, the population projection has been transformed from what we call the standard cohort component model to micro simulation models. This kind of potentially provide ground for microsimulations for projections for health professionals as well. So it provides, you know, the future estimates of number of people by age and gender, and also by immigration status and region. That opens up, you know, sometimes, you know, the possibilities of including other more detailed characteristics. And for example, the race and ethnic origins and also regions. And we have also access to very extensive health and care service usage data. We have data from what we call the Norwegian Patient Registry, which basically on data on kind of specialist health services. We also have what is called the Norwegian Control and Payment Health Reimbursement Database, which have data on local level care services. And also we have data on GP and physiotherapy consultations that we're basically in the primary care. So this data is basically on the usage, how much each individual use the health services, and combined with the labor input data, where basically the registered employment statistics, basically we observe, you know, how many, which person work in which places and how much they work and all the information on that one. This gives us all, you know, the number of full-time equivalents, FTEs by service, educations, and also age and gender of the health professionals. We link, and also we have data on education and qualification registers, you know, which contains information on all health authorized and qualified health professionals who lives in Norway. We use the linked utilization data and the labor input data for demand projections, because it gives us the utilization patterns and give us, you know, what we call transform that information to FTE required. And we use the linked labor input data with education and qualification register for the supply side mainly, because that gives us the labor supply behavior for each available health professionals. And based on, and then I can start with the supply side of the health mode. You know, this is relatively straightforward. We have 3 key components here. The first is the number of authorized professionals in Norway for a given year, and characterized by gender and age, and also health occupations. And we also have try to work out the probabilities of those people working within the health sector, because not every health professionals was active in the labor market. Even if they are active in the labor market, they might work in other sectors, for example, in education sectors, you know, or not necessarily everybody who have qualification as a nurse going to work in health sector as a nurse. And for those who work within the health sectors, we try to work out the amount of labor supplied per individual, given that they work in the health sector. So the second is basically what we call in economics the extensive margin, and the third one was the intensive margin. I'm going to look at for each of the key components very briefly. Let's start with the stock of the authorized professionals. This is essentially a very simple stock and flow models. So starting with example for, you know, those who authorized nurses in Norway in 2019. And then we start with that one, and we try to see, okay, what will be the 2020s nurse stock in Norway. We use that from 2019. We add in the new entrants, which will include, you know, the graduates from the education sector. You know, there will be like those who are domestic trained and also those who are foreign trained. There are rather many in Norway. Those many new graduates coming from like, you know, foreign medical schools. You know, because there's rather limited slots, competition to get into especially the doctors, the medical doctors, the education is very, very high. So many choose to kind of get education from foreign countries and then come back to Norway. So we account for both of those things. And we also look at how many immigrants which has the health professional qualifications. We added those, we consider those things, those are the new entrants. And then we minus, those who leave the country, those who out-migrated, and those who die. And that gave us, the authorized nurses in 2020. And to model the inflow and the outflow, we use data from this qualification registers, where for 2 years, 2019 and 2018. And in our benchmark scenarios, we assume that the patterns will be retained in the projections. And so basically we assume, okay, the inflow and outflow will be same as what happens from 2018 to 2019. We also look at, these patterns over time. They seem to be quite relatively stable over time. But in the different scenarios, we look at, how the sensitivities of projection to different assumptions, for example, change in number of professionals to trained. And to model the inflow and outflow, we model both in two aspects. The first thing, we model the what size, how many of those are come in or come out, and also we model the distribution of characteristics. For now, we only look at age and gender, so we assume that the distribution of those people come in and those people left the stock have the same distributions. And we denote the stock of the authorized health professionals by gender and age. So as kind of MG of A, as kind of like, okay, you have different age and gender, how many of those for different kind of education groups. And then we want to model the labor supply behaviors, given that you are qualified health professionals. We look at hours worked for health professionals who employed in the public sectors. Also, those who employed in private sector but are funded by the public sector or working on behalf of public sectors. But we don't really consider, we don't have information for those who purely private. So we look at working status and hours work, FTEs. We use two models, similar to what I had talked about, three key components. The second component, decision to work in the health sector. We use a logical model for that one, and also decision for how much one to work, which we use kind of standard OS. And this is an example for female nurses. The orange line was the observed working rate in the left panel, and the blue lines is predict work rate. As you can see, there's the decision to work in the health sector is pretty high for up to like 60 years old. It's more than 80%. And after 60 years old, of course, they're coming into retirement and other things, you go down. And on the intensive margin, you see that there's up to like 60 years old, they actually work quite a bit, like 90% on average. That's quite high. So in a way, when you think about possible potentials for increasing them to work more, there's not really so much to get, but we still kind of use scenarios to study the effect of promoting higher labor supply. For example, we're going to talk about one thing we use is try to delay retirement or increasing the intensive margin labor supply. And in a way, for simplicities, you can understand that the supply of labor in health sector is given by the product of three factors we discussed earlier, and the number of qualified professionals, and the probability of work in the health sector times the labor supplied if you work in health sector. all this is measured in FTEs. In practice, the supply is projected for each individuals in the stock populations, and the final supply is given by the sum of all of these individuals. And the demand side projections are a little bit more complicated. There are many different ways approaches that are used. For example, from the simple things where you use provider population models, or to the need-based approach, like I think that was what the Australian models was used. You look at using the populations, and then you estimate using health conditions and other things, try to look at needs. We choose a more easier solutions, more in the spirit of what we call the utilization models. We estimate the demand based on observed utilizations. So what we do is that we start with the underlying populations, who needs the healthcare, and then we, based on what we have observed utilization patterns estimated from the data which we have, then we project the demand to different health services. For example, hospitals, general practitioners, home care, etc. So those are what we do is 14 different type of services, and then we count, because that it will be okay. How many we need, for example, FTEs in the hospital sector. But what we have to translate that one into individuals, health professionals, FTEs, because in the health sector, in the hospital sector, for example, you have different type of health professionals. You have doctors, nurses, and other supporting health professionals. So we need to use what we call the conversation parameters, transfer from the services to occupational groups, and then reach to the future healthcare needs by the occupation groups, also measured in FTE. Let me just go through the demand side very quickly. For the healthcare, to get the healthcare services FTE demand, we also have 3 different components in here. First is the base of the projections, which is what we call which is the population in Norway, projected by the population projections, and then we try to estimate the probabilities that a person, a resident in Norway, kind of take contact to different type of health services. For example, how often a 14 years old boy will contact, for example, hospitals. How often he will contact, for example, the general practitioners. So that's similar to the supply side. This is the extensive margin estimates, and then given that you are contact the services sector, and then we try to estimate, how much on average the healthcare needed per patient, also in FTEs. Let me again try to look at these 3 different factors one by one. The first one is the future population in Norway. This is also something which I'm involved in. So this is national population projections, and we have 15 different scenarios. As we can see here, we use what we call in the health projection, we use what we call the main alternatives, which assume like medium level infertilities, life expectancy, and immigrations, and which is the middle blue, the dark green curves in the figures to the left, to the right, and then we have also different scenarios which we also use in the health projections, and in different assumptions, we can see here, the age compositions are quite different. So that are going to be also give difference on the utilizations on the future health needs. For the intensive margin and extensive margin utilization parameters, we use data from the health employment registers, the patient's usage registers from 2019 and earlier years. We try to define the utilization by two factors. The first was, what we call the man years per user, which we call it also standard, measures the quality and quantities of healthcare services provided to each users on average. And of course, this depends on productivities, right? And qualities. And also the second part, we use what we call the user frequencies, which is how often you contact the health sector services, health services. This depends on health conditions among populations. At the current versions, we don't really take account into the health indicators on the individual level, such as, for example, BMI, smoking status, and other diagnoses, or other socioeconomic conditions like income and educations. We don't consider race and ethnicity, immigration status. We don't really consider geometric locations. So that's something which we are thinking about to extend the model. And to get this utilization parameters, because we have different distinct categories services in our model, and for each of the categories, the man year per user is defined from different indicators, which depends on the nature of the services. For example, in the hospitals, we have the DRG points. We try to translate the DRG points into the FTE. And in nursing homes, we use bed days. For the general practitioners, we look at the consultation numbers and the time. So our combination of this one. The good thing is that we try to use combine different sources of data, try to get a standardized measure for this demand intensive measures. And here's an example of what we have here. The top left is the utilization profiles by age and gender. And I picked the dark curve is for men and the light blue is for women. And then I look at, for example, for 80 years old man who take contact to hospitals, on average, use 4-time equivalent of 0.09. So it's like 0.09 man years. And the bottom right is the total required FTE for the whole Norwegian populations in the house in the hospitals. That's basically the one which on the top left and aggregated by the number of individuals in our population. So you see that we have a hump for women in 30 to 35 years, corresponding to probably to the pregnancy, and we also have a hump up peak in for people who in 70 to 80 years old, which corresponding to the most of people old people there. And again, we can very similar to the supply side with demand projections is actually try to simulate it on individual level, but we do in the bigger picture, it can be seen as a product of those three components. And here is the 4-time equivalent in public health and care services by age and patients for 2019, and which is light blue, to 2040, which is dark blue, which is black. So you can see there's large increases. The FTE required in 2019 is 315,000, and in 2040 it will increase to 424,000. And from the services, we now have the FTE required for different type of services. We have to map this one to occupations. With this, we use what's so-called the conversion parameters, or in the US, I think it's called the staffing ratio. And that is based on the composition of the workforce within the different healthcare services for the year of 2019. For each services, the FTE of each occupation groups required for 1 FTE provided for that services. So that's the ratio. And then in the benchmark scenarios, we assume that delivery patterns will remain unchanged. Of course, we in the scenarios we study, impact of the different mixture of the institutions, staffing ratios, and like those things. The total project demand for each type of health services, we distributed that one according to this compositions. And here is a example of the conversion parameters used in the projections. And this is for hospitals, so this is somatic institutions. We can see, the largest share is nurses, that contains around like 40%. Doctors contains around like 16% to 17%. We also have other supporting patterns, and this is something which we use. And we have in the projections sometimes use different things. For example, in 2040, we have a different set of conversion staffing ratio. For example, we see that in 2040, we're going to see there's increase in doctors and nurses and a little bit less required from other supporting occupations. And to bring the supply and demand together, what do we have? We have this what do we call the gap analysis. We try to see how we should kind of say what is the future unmet needs in the future. But the supply and demand are projected independently from each other. So in a way, we ignore the potential equilibrium adjustment through market mechanisms. For example, we ignore market responses through wages and other incentives. We also don't really consider individual adjustment. But we know that different type of health care workers overlap in the ability to provide services. So skill mixing was not considered here. Right, so we don't really consider the possibility that shortage of one type of professionals would lead to other groups being hired instead. And we also in the gap analysis we also look at the demand was based on the quality and standard of the base year. Right. We of course in the scenarios we studied different impacts of some different assumption on this one. We also account for the unmet demand at the base year because there's vacancies. We have information on vacancies on doctors and nurses for in the year of 2019. So for example, we have around missing 5,500 nurses in 2019 already, and we're missing 600 FTEs for doctors. We try to account for potential change in informal care as well, but this part we are lacking information. So this is very imprecise estimates in this field. And
thank you so much, Jia. I'm just gonna. Yeah. I don't mean to interrupt you. I just want to make sure we have enough time for our discussion. So if it's possible, if you can give us your concluding thoughts, and then we can move on to the discussion. Thank you so much.
Yeah, exactly. I'm down in 2 slides. So we have some example scenarios. So we want to, in the supply side, we have increased the immigrations. We have in the delayed retirement. In the demand side, we have changing in the working force compositions. And to communicate our population, our projection result, we have also written reports, and also we try to develop a kind of dashboard. I think this has been used widely in this one. So that is part of things which we try to work on. Our dashboard is still kind of preliminary, so we're trying to work more on that directions. So So there's a lot of things which can vary. This is a very short, brief introductions for what we have done in Norway to use the projections, and really eager to learn from others and try to improve our models while keeping its transparency and easy to track models. Okay, great. Thank you.